Welcome to the deep dive.
Great to be here.
Today, we're tackling a really common health issue, periodontal disease.
Yeah, gum disease.
Right. We've got some pretty detailed lecture notes here. They cover, well, pretty much everything from the basics right through to treatments. And our goal, our mission, is really to unpack all of this for you. We want to draw out the key info so you can properly understand the condition, and what it means.
Sounds good. Let's get into it.
Okay, so let's dive in.
It's interesting. We often think dental checkups are mostly about cavities.
Yeah, fillings and things.
But there's this whole specialty, periodontics, just focused on preventing and treating periodontal disease.
And the notes make it really clear right away this isn't some minor thing.
Not at all. It's actually the #1 cause of tooth loss in adults.
Wow. That really puts it in perspective.
It really does. Shows why understanding it is, well, pretty crucial for keeping your teeth long term.
Absolutely. So when we look at what starts it all, what gets the ball rolling, the lecture notes point to a few key culprits. And right at the top, plaque.
Ah, plaque.
Yeah.
That fuzzy stuff.
Exactly. But it's more than just fuzzy stuff, isn't it? It's like a whole community of bacteria.
It is. And they produce acids, which irritate the gums. That's the initial inflammation.
Okay. And if you don't get rid of that plaque...
Then it hardens, becomes
Yes.
calculus or tartar.
Right, calculus. And the notes say something interesting here. It's not just hardened plaque, it's rough.
Exactly. Its surface is rough, which acts like, well, kind of like sandpaper against the gums.
Ouch.
And worse, it gives bacteria even more little spots to hide and grow.
So it makes it harder to clean and irritates things more.
Precisely. It fuels the inflammation of the periodontium. That's the whole support system, gums, bone, everything.
So it sort of feeds itself like barnacles on a ship, creating more surface area.
That's a great analogy. It really does become a bit of a self-perpetuating cycle.
Makes sense. And this ongoing irritation, this inflammation, if it just keeps going.
But that's when you get into more serious territory. Bone loss.
Right. The notes explain that this constant inflammation actually causes the jawbone holding the teeth to shrink back, to reduce.
Yeah, and that's obviously bad news for keeping your teeth stable.
Definitely.
And, thinking bigger picture, that bone loss is really the line in the sand. It separates the early stages from the later, more serious ones.
So, like, gum inflammation might be reversible?
Often, yes. But once that supporting bone starts to go, you're dealing with something more permanent, more advanced.
Gotcha. The notes also mention sensitivity, right? To hot or cold.
And even just tenderness if you touch the gums, which makes sense, doesn't it? With all that inflammation and maybe the gums receding a bit.
Yeah, it does. Now, it's not just about what's happening right there in your mouth, is it? The lecture talks about systemic links.
Absolutely. Connections to your overall health. Diabetes is a big one.
How?
Well, the notes say it can impair healing and basically ramp up the effects of inflammation.
Interesting. So it's like a two-way street.
Very much so.
Huh.
With diabetes, for instance, higher blood sugar can feed those mouth bacteria and also make it harder for your body to fight the infection.
So gum disease can get worse faster.
Exactly.
Yeah.
And similarly, the lecture points to AIDS. By weakening the immune system, it can dramatically accelerate how quickly the disease progresses.
And it's not just those two, right? Other immune issues.
Yeah, other conditions affecting the immune system can definitely play a role in how your body handles that plaque bacteria.
Okay, so moving on to symptoms. What are the actual warning signs? The things that might make someone think, uh-oh, maybe I should get this checked.
The lecture materials lay them out pretty clearly. Bleeding gums is a big one.
When brushing or flossing.
Yeah, or even sometimes just during a gentle dental exam. It's a key sign of that inflammation we keep talking about.
Okay, what else?
Changes in gum color, like looking redder, maybe even purplish.
Suggesting inflammation or maybe poor circulation.
Could be. Also, swollen gums, another pretty obvious sign of inflammation.
Right. Those seem like things people might actually notice themselves.
They might, but then there are things a dentist is more likely to pick up on.
Like the pocket depth stuff. The lecture mentioned an enlarged sulcus.
Exactly. The sulcus is that tiny groove between your tooth and gum. Normally, it's shallow,
Okay.
but as inflammation kicks in, the gum tissue pulls away slightly, and that space deepens. That's your periodontal pocket.
And that's bad because...
Because it's the perfect trap for more plaque, food bits. Makes it way harder to clean.
Another vicious cycle.
Pretty much. The lecture also lists persistent bad breath, or maybe a foul taste. That often comes from the bacteria and gunk trapped in those pockets.
Makes sense. And eventually...
In more advanced stages, yeah, you might feel your teeth getting loose, or even notice changes in how your teeth bite together. That's called malocclusion. It happens as those supporting structures weaken.
Wow, that paints a clear picture of how it progresses. And the lecture actually breaks this down into stages, starting with gingivitis.
Right, gingivitis is stage 1. The good news here, it's basically just inflammation of the gums.
Just the gums.
Primarily, yes. And importantly, the lecture stresses. No bone loss at this stage.
Yeah.
And it's often reversible. Good brushing, good flossing can usually turn it around.
So what causes gingivitis mainly? Still plaque.
Plaque is the main driver, yeah. But the notes also mention hormonal shifts. Think pregnancy, puberty, and even a lack of vitamin C can make gums more prone to it.
So gingivitis is kind of like the body's early warning system, a chance to fix things.
That's a perfect way to put it.
Yeah.
A chance to get back on track before it gets more serious.
And if you don't treat it.
Then it can progress to periodontitis. Now the inflammation goes deeper.
Deeper how?
It starts affecting the periodontal ligament, the other tissues holding the tooth in place, and that periodontal pocket we mentioned, that definitely forms at this stage. Plaque and debris really get stuck down there.
And the lecture mentioned something about fibers.
Yeah, the fibers that attach the tooth root to the bone, they get diseased and start to break down. That attachment weakens.
Okay. And periodontitis itself has levels, doesn't it? Early, moderate, advanced, based on those pocket measurements.
That's right. Early periodontitis, inflammation reaches the top of the bone, pocket depths maybe 3 to 5 millimeters.
Still relatively shallow, but deeper than healthy.
Right. Then moderate periodontitis, more destruction happening. Pockets deepen to maybe 5 to 7 millimeters.
Okay.
And at this stage, you might start seeing involvement of the furcation. That's where the roots branch on multi-rooted teeth, and maybe slate tooth movement.
And
Advanced periodontitis. Pockets are even deeper, say 8 millimeters or more. Furcation involvement is common, and noticeable tooth mobility is usually there too. It's quite a progression from simple gingivitis.
It really shows why those regular checkups and measurements are so vital. Now, we touched on systemic diseases earlier, but the lecture gives more specific examples.
It does. Diabetes comes up again, highlighting that gum disease isn't just more common, but can show up differently, like gum overgrowth, faster bone loss, even abscesses, and general mouth pain.
That's significant. What else? Epilepsy?
Yeah, specifically a medication for epilepsy, phenytoin, or Dilantin. It can cause gingival hyperplasia, basically, gum overgrowth, in a fair number of patients, maybe 25–50%.
Wow. Can that be treated?
Often, yes. The notes say good plaque control helps a lot, and sometimes minor surgery can manage it. So that's a direct drug effect on the gums.
Very direct. And leukemia.
With leukemia, the cancer affects blood cells. An overproduction of white blood cells can actually show up in the mouth as gingivitis and bleeding gums.
Another systemic link. Hemophilia.
It's about blood clotting. Since their blood doesn't clot properly, the lecture really emphasizes the need for super gentle home care. You want to avoid any gum scrapes that could bleed excessively.
Makes sense. And A's, we mentioned the immune system impact.
Yes, the weakened immunity often leads to really chronic, aggressive periodontal disease. The body just can't fight off the infection effectively.
And there was one more mentioned, ANU.
Yes, acute necrotizing ulcerative gingivitis, ANU. That one's pretty severe.
So?
It comes with really foul breath, ulcers on the gums, actual dead or dying gum tissue, that's the necrotizing part, and often the person feels generally quite ill. It's much more intense than typical gingivitis.
Sounds nasty. Okay, so diagnosis and treatment. How does a dentist figure this out, and what do they do?
Well, the lecture outlines a thorough process. X-rays are key periapicals, bite wings. They let you see the actual height of the alveolar bone, the tooth support.
So you can see a bone loss has occurred.
Exactly. Then there's probing, using a little measuring tool to check the pocket depth around each tooth.
How many spots?
The notes mention 6 specific points around every single tooth. Mesiofacial, facial, distofacial. Then the same on the tongue side. Mesiolingual, lingual, dislingual.
Wow, that's detailed.
It has to be. They record all those numbers, track them over time. It gives a really precise map of gum health.
So those measurements really tell the story. And then treatment?
Treatment starts with instrumentation, basically removing the plaque and calculus.
The stuff causing the problem.
Right, both above and below the gum line. This could be a regular cleaning, a prophy, or maybe a more intense full-mouth debridement if there's a lot of buildup.
And scaling and root planing?
Yeah, those are more targeted. Scaling scrapes off calculus, And root planing smooths the root surface to make it harder for new plaque to stick.
Okay. And what if that's not enough? Surgery?
Yes, if non-surgical methods don't resolve things, especially deep pockets, surgery might be needed.
What kind?
Several types. Gingivectomy is surgically removing diseased gum tissue to reduce pocket depth.
Okay.
Gingivoplasty is more about reshaping the gums, maybe removing excess tissue to create better contours.
And grafting?
Gingival grafting, yeah. That involves taking tissue, usually from the roof of your mouth, and transplanting it to cover exposed roots or build up thin gum areas.
Right. And bone reshaping?
That's osteoplasty. Surgically reshaping the underlying alveolar bone itself, maybe to improve the contours after disease has affected it.
Seems like a pretty comprehensive toolkit for tackling this.
It really is.
Easy.
Tailored to the specific situation.
Okay, so wrapping up this deep dive based on these lecture notes, it's really clear periodontal disease is, well, incredibly common.
Yep, driven by local stuff like plaque and calculus.
But also hugely influenced by our overall health, like diabetes and immune status.
Absolutely. And early detection, consistent treatment, they're just vital to stop things progressing to tooth loss.
That really seems to be the key takeaway. Manage it early.
Definitely. And, considering those strong links, we talked about systemic health affecting oral health and maybe vice versa. Kind of makes you wonder, doesn't it? How much could focusing more on oral health actually boost our overall well-being?
Yeah, could it even help spot other health problems earlier?
Perhaps. It certainly raises some questions for all of us, for you listening, about your own health and maybe how you approach preventative care, right?